Hi, welcome to the three-part webinar series on the National Social Life Health and Aging Project, NSHAP, Advancing Interdisciplinary Clinical Research. Today's webinar, Medication Data and the Next Generation of Dried Blood Assessment, is in conjunction with the GSA 2020 Annual Scientific Meeting online. The webinar is being recorded and will be posted on the GSA website. A notice to all attendees will be distributed once the recording is available. A question and answer session will immediately follow the live presentations. We will be accepting questions through the questions feature accessible on the right-hand side of your screen. Opening today's program is Dr. Louise Hockley. So without further delay, I'm going to hand the microphone to Louise.
Good morning, good afternoon, good evening, depending where you are in the world. I'm happy to host this third of the three webinars on the National Social Life Health and Aging Project. As we'll show you, there are some very valuable data in NSHAP that have fueled some very impactful research in the clinical and medical arenas, as well as in the social sciences. And we hope to be helpful in pointing you to those data and how to use them, examples of how to use them. So we have a wide range of investigators on this project, clinicians, epidemiologists, sociologists, psychologists, geriatricians, and so on. The primary aim of NSHAP is to understand how the social world gets under the skin to affect health. And just as easily, we ask the question in reverse, and you could too, how does health and illness affect social functioning? Specific examples might include, how does experiencing discrimination affect risk for inflammation? Does cognitive limitation damage social relationships, going in that direction? And poor hearing, does that increase loneliness? There are a number of domains of inquiry in NSHAP, and I'll walk through these broad domains in some summary, I guess you could say. The social domain, excuse me, NSHAP is exceptional in that it collects a social network roster that identifies close confidants of that person, so one can estimate social network size. You can also estimate relationships with and among network members. NSHAP also probes other aspects of social relationships, like number of friends and close relatives, social support, social strain. Social participation includes things like how often people gather with others in groups, religious services, volunteering, and lastly, NSHAP asks some detailed questions about sexual attitudes and behaviors of older adults, an area that's largely unexplored in large national surveys. In the health domain, there are a number of self-reported measures of physical mental health, activities of daily living, and instrumental activities of daily living, and reports of doctor-diagnosed chronic conditions. NSHAP has also developed a range of performance measures under the advisement of clinician consultants, so things like gait speed, chair stands, also measures of cognition, performance measures. NSHAP also obtains a complete medication inventory and blood tests for hemoglobin A1C and CRP, among other analytes, and objective assessments of all 5 senses. In the, from a contextual and lifespan approach to health, you see in NSHAP measures of childhood experiences, employment, income and health, wealth, and respondent perceptions and interviewer assessments of the household and the neighborhood. NSHAP also probes respondents about their attitudes on a range of topics and obtains assessments of the 5 main personality traits. The study design, the study started in 2005 to 6 with 57 to 85-year-olds born from 1920 to 1946. That was 3,005 respondents, and it has been going on every 5 years since for a re-interview. In 2010 to 11, the partners of those respondents were added. In 2015 to 16, a new cohort, so-called baby boomers, were added, those born from 47 to 65. And then we have another wave planned, which was to have been this year, but like much of the rest of the world, things changed this year. We're going back to these people in 2021. We are in the interim, however, collecting some data for their experiences during the COVID pandemic. The webinar format follows this general procedure. We will have 2 presentations of clinical medical content, followed by a discussion of data and analytic issues and recommendations. That, as Judy pointed out, will be followed by a Q&A section. You can use the questions tab on the interface to enter your questions for the panelists, and we will use the chats for supplementary information for you. Jen Hannes will moderate the question and answer session. She is familiar with NSHAP right from its beginnings. And then, as what Judy mentioned, this webinar is being recorded and you will be able to find it on the GSA website. So what have we done so far? In October, we had Drs. Cotwell and Heising-Sheets talk about cognitive function, physical function, and accelerometry measures in NSHAP. On October 15th, we talked about sensory functioning and the remote assessment of performance measures in the National Social Life Health and Aging Project, and that was with Dr. Jay Pinto and Martha McClintock. Today, we're going to be talking about medication data and the next generation of dried blood assessments in NSHAP with Drs. Huang and Cato, followed by Phil Shum talking about the data and analytic issues. Just to introduce folks, here's Dr. Huang. Unfortunately, you don't get to see him in the flesh, but this is, trust me, is what he looks like. He is a general internist who studies clinical and healthcare policy issues at the intersection of diabetes, aging, and health economics. His main research focus is in the area of medical decision-making for elderly patients with type 2 diabetes. Dr. Cato does research that uses population-based methods to better understand the underlying mechanisms responsible for the use, underuse, and unsafe use of medications and how these patterns may influence health outcomes and health disparities. And as I mentioned, Phil Shum, who will be talking about the data that corresponds to these content areas, is an NSHAP investigator who's also been involved with the project since its inception. He is a statistician, assistant director of the Biostats Lab, director of the Research Computing Group in the Department of Public Health Sciences at the University of Chicago. He is responsible for developing and implementing statistical approaches to the analyses of NSHAP data, as well as the preparation and maintenance of the public data set. And with that, I will turn this over to Dr. Huang.
Thank you, Louise. And thank you for all of you for attending this webinar. We hope it is valuable to you. And during the course of this talk, Dr. Cato and I will be going back and forth. And in some ways, we're trying to illustrate how different sources of data, in particular medication data, dried blood spot assessments, and also survey data can be used together to provide unique insights into medication prescribing and chronic diseases. So this outline is pretty simple. We will talk about how NSHAP has historically and continues to collect medication data and codes the data for medications. I will talk briefly about dried blood spot assays, which you may have heard about in a prior webinar with Dr. McClintock. I'll re-describe that briefly and how we're changing procedures with the 2021 data collection. And I think what will be most valuable to you is to see examples of analyses. Dr. Cato will talk about how the medication data in NSHAP have allowed us to provide insights into trends in specific therapeutic classes, medications. She will talk about how the data allows us to study concerns for older people, including polypharmacy, and how issues such as social and mental health can be studied with medication. I will then show you how the data from medications, dried blood spot assessments, and surveys can allow us to triangulate around defining health states for patients, giving us a comprehensive view of whether or not somebody has a condition or not. So without further ado, I will pass this now on to Dr. Cato.
Thanks, Albert. So in terms of the medication data, I think the one key strength of NSHAP and other surveys, but mainly NSHAP, is that the data is collected during an in-home interview, and the interviewer directly observes the medications the respondent is taking. In response to the question, you know, we want to record all the medications you're on and you're taking regularly. And this includes prescription, non-prescription, over-the-counter, as well as vitamins and other herbals and alternative medicines. And that's important because a lot of other data sources, including surveys like NHANES, either just focus on prescription medications or they have kind of a 1 month recall period. So they don't necessarily measure regular use, which is important in terms of clinical and health implications. And they exclude dietary supplements and over-the-counter medications. And claims data, which is often used in pharmacoepi, including pharmacoepidemiology studies of older adults, is not only limited to prescription medications, but it's fill data, right? So it excludes many people, it excludes non-prescription medications that may not be adjudicated through insurance or dispensed at the pharmacy directly. And it excludes people that don't have insurance or may not use the pharmacy to get their medications. So that's kind of an important strength of NSHAP, and it's allowed us to do some important analyses that have otherwise been ignored. So the medications are directly recorded, and the interviewer is instructed to record up to 20 medications. Next slide, please. So that medication, kind of raw medication data is then cleaned and coded. So all drug entries are renamed to a generic drug name, and that's using various public data sources, including the NDC directory, the National Library of Medicine, but also other Google searches sometimes are needed. And they're linked. These generic drug names are then linked to the Multum drug classification database, which categorizes drug names at the generic drug name level to a hierarchy of therapeutic and pharmacological drug categories. And that's important just in terms of, you know, using the data analytically. We also coded medication names based on their regulatory status, so whether a medication was prescription only, over the counter, or a dietary supplement. And dietary supplements include nutritional products as well as alternative therapies. Next slide, please. So this is kind of just an example of the Multum drug classification hierarchy. So if we just think of hydrochlorothiazide, that's the drug name, and it's at level 3, it's under thiazide diuretics as a pharmacological drug class. At level 2 of the Multum drug classification, it's under diuretics more generally. And then at level 1, which is the more aggregate level, it's under cardiovascular agents. So if someone's interested in antihypertensives or diuretics, you kind of have to go more granular. You have to go to level 2. If you're interested in looking at hydrochlorothiazide or thiazide diuretics, you would want to capture the information at level 3. And Multum also allows us to differentiate combination products from not, so it's at the actual product level. So this is an example of a commonly used medication combination of hydrochlorothiazide and lisinopril. And we're able to capture it under both, but it's under antihypertensive combinations, but you can also get it at the drug name level. So if you're interested in examining hydrochlorothiazide, it'll capture both combination and non-combination medications that include hydrochlorothiazide as a product. Next. I think Albert, you'll take on from here.
Thank you, Dima. So this is just a reminder that for the dry blood spots, for the first 3 waves of NSHAP, this picture shows you the actually the card and the procedure in which a research assistant collected dry blood spots from individual participants in their home. You can see that the research assistant is with the gloved hand is squeezing the finger of the participant and producing 5 discrete spots that land in those circles. These cards are then dried and then shipped with a temperature monitor to, at least in the last wave, temperature monitoring was added to detect wild excursions in temperature during shipping. In particular, high temperatures can alter the results of these assays, so that's why it's important to monitor temperature. And the dry blood spots allow us to perform at least the force assays below on a regular basis in NSHAP participants. Epstein-Barr virus antibody titers to give us a sense of a person's immune system. C-reactive protein, an important marker of general inflammation, and for many models of aging and the development of chronic disease, inflammation is thought to be an underlying biological mechanism. And then we have, of course, our marker of diabetes, hemoglobin A1C, which is the proportion of hemoglobin molecules with with glucose attached to it that reflects average blood sugar over the last 3 months, and is used historically has been used for management of diabetes, but then at least since 2011 has been designated as one of at least 3 different options for diagnosing diabetes. The hemoglobin A1C also allows us to detect pre-diabetes, and because of the systematic collection of this measure, we can track transitions in diabetes health states across the population. And lastly, we also assay hemoglobin, which is the amount of oxygen carrying molecule within red blood cells that is necessary for interpreting the hemoglobin A1C, but also allows us to do studies of anemia in older adults as well. There are other assays that, because the dry blood spots are stored in freezers, these spots can be brought back for puncture and consideration for new assays, including assays for we actually just spoke recently about using the assays for genetic expression studies. So because of the pandemic, we have been working very hard to develop new procedures for having participants in NSHAP collect blood on their own without a research assistant. And we have done some pretty exhaustive internal testing with 3 or 4 different devices that are now available. And our current plan for wave 4 is, at least for remote assessment, to have patients collect blood on their own with this Tasso device. That you sort of see in this picture that the Tasso device has a big red button, and below you see this you can see this collection essentially is similar to filter paper, but on the top part of the device is the puncture that happens in the shoulder of the subject, and then blood drips into the four different wells, and then those are the subject for future assays. So the devices that were available now on the market vary from essentially subjects redoing dry blood spot assays on their own with their fingertips, but we found for ease of use that this is likely to be pretty effective in collecting, increasing the odds of having a subject return the dry blood spot samples. And the same lab that performed the assays for waves 1 through 3 will be performing the assays for wave 4 with the Tasso device. So back to you, Dima.
Yeah, thanks. So I'm just going to present a few examples of how we used the NSHAP medication data. One, to look at utilization, and the second would be to look at underuse before we get into polypharmacy and adverse effects on mental health. So for this analysis, we were interested in looking at how the use of medications overall and by type. And by type, I mean prescription, over-the-counter, dietary supplement. Again, this is a really important strength of the NSHAP medication data, that it captures over-the-counter medications and dietary supplement data, dietary supplements, which are not always safe, they're not always necessary, and their benefits and their risks are kind of are less regulated than prescription medications. So it's important to know the extent they are used in the older adult population and how they're used together. So here, this is comparing wave 1, so 2005 to 2006, in men and women and overall. And we saw, there was an increase in general in the use of any medication, including dietary supplements. But what's interesting is that the use of 5 or more prescription medication increased from like 30% to more than 35%. And 5 or more is the general kind of measure of polypharmacy. And that's associated with increased mortality risk in older adults. So it's kind of arbitrary, but it's a generally accepted cutoff in terms of number of medications. We also found that over-the-counter medications declined in general, which was interesting, a little unexpected, but it's driven by a variety of factors, including a lot of over-the-counter medications certain types not being used or withdrawn from the market. But I think dietary supplements, again, an important component of older adult health. We found that more than half of older adults use at least one dietary supplement, and about a third use 2 or more, and more than 10%, or about 10%, use 5 or more dietary supplements. So it's an important part of the medication taking behavior of older adults. Next slide, please. So NSHAP can also be used, and we've used it to look at disparities in the use of specific classes of medications. And here we focus on statins, which is a large drug class that includes, simvastatin, atorvastatin, among the most commonly used medications in the US overall, but also in older adults. And it's indicated for the prevention of cardiovascular events, particularly for people that are high risk for having cardiovascular events, so in primary and secondary prevention. And we found, because NSHAP captures everyone, nationally representative, it's not limited to people that use medications or people that have insurance, which is really the population that's captured in claims data. And it asks patients to, to bring out medications they take on a regular basis. So it's not necessarily a measure of adherence, but it's a measure of regular use. So this is what they take regularly. And that's up to the patient to kind of make that decision, but we're pretty explicit in telling them what you take every day or at least weekly. And we found that there were disparities between Black, non-Hispanic, and white non-Hispanic older adults in terms of statin use. So 50% of whites at high risk were using statins compared to 38% of Blacks at high risk. We also saw that aspirin use, an over-the-counter medication largely, very cheap. We also found disparities there. Aspirin, another medication, indicated in most, but not all, older adults at high risk for the prevention of cardiovascular events. And these disparities persist even after we account for insurance, you having an unusual source of care, age, gender, education, income. So a lot of the factors often used or implicated in disparities in medication use, we found when we're using this larger nationally representative data set that includes everyone, including those that don't have insurance, we found that insurance doesn't explain this gap in medication use, which is very important given that cardiovascular events are the leading contributor of health disparities in the US. Next. So for the next few slides, I'm going to focus more on how we've been using the data to look at the impact of polypharmacy on adverse effects in social, mental health, and well-being. And this is important because a lot of the work focuses on physical health, including ours. So we look at drug-drug interactions, but we look at drug-drug interactions in terms of OTC as well as dietary supplements, again, something that you can really only do with these national survey data like NSHAP. But we also look at, and NSHAP allows us to look at other factors that not only affect the propensity or the risk of adverse drug effects, but also allows us to measure some of these outcomes like sexual dysfunction, sleep, particularly insomnia, depression, and these other factors that are captured to a certain extent in NSHAP. And I'll be kind of focusing on sleep and how we used NSHAP to look at drugs, medications that have sleep side effects, specifically insomnia. And we leveraged and used the measures of sleep in NSHAP to look at if there's an association between polypharmacy or the use of multiple medications with these insomnia side effects on insomnia symptoms. We also looked at drug-drug interactions and drinking, another one that we examined. Again, NSHAP captures information on alcohol consumption or drinking behavior, and we were able to integrate that with information, drug safety information from a kind of widely used database, Micromedics, to examine the extent to which older adults drink and concurrently take medications that interact or should not be used or should be avoided when consuming alcohol. So this slide here shows our analyses of drug-drug interactions, and what we found is that they've almost doubled between 2005 and 2010, so over a 5-year period. It went from 8.4% of older adults had at least one major drug-drug interaction, and major being defined as potentially fatal or life-threatening. That increased to 15% in 2010, 2011, so wave 2. And that's, not good news that more older adults are taking medications together that they shouldn't be taking. And if we examine what by kind of drug combinations, whether it's prescription or prescription and non-prescription and dietary supplements, we see that, this increase was largely driven by the increased use of simvastatin with an antihypertensive amlodipine that went from 1% to 4% during this 5-year period. And it also was driven largely by the use of dietary supplements and over-the-counter medications. So again, medications that you're really not able to capture in other data sources, and these survey data really allow us to understand what's going on in terms of medication taking behavior in older adults. So we found like aspirin, some naproxen, omeprazole. A lot of these medications are available increasingly over the counter, and dietary supplements like omega fish oil and niacin are used in combinations that should be avoided because they increase the risk of bleeding or renal failure, which we know are leading causes of hospitalizations for adverse drug events in older adults. Next. So this is our analyses that were published that look at drug-alcohol interactions. And we defined regular drinkers as those that had consumed alcohol at least 1 day a week on a regular basis. This is based on just the measures that are used and in general and in NSHAP. And we also stratified them by light, moderate, or heavy drinking, just in terms of the magnitude of the drinking behavior. And we found that in prevalence of drug-alcohol interaction, which we defined as someone who regularly drinks alcohol and is concurrently taking a medication that interacts with alcohol or should be avoided. And we determined that list of medication based on micromedics, and the same kind of drug safety database that we use to identify drug interactions, also captures information on drug-alcohol interactions. And what we found was that the prevalence increases with age, and it's higher consistently in men than in women across all age groups. And overall, about 20% of older adults are actually regular drinkers and taking a medication that they shouldn't be taking while they're drinking. Again, that's important because in terms of the adverse effects and adverse events associated with these drug-alcohol interactions, which include CNS depression with anti-diabetics, and it could lead to lactic acidosis and a lot of hypoglycemia. Again, these are leading causes of hospitalizations in older adults, and alcohol drinking behavior may be contributing to that. Next slide, please. So we examined, just because we were interested in kind of what are the classes that are implicated here. We found that it varies. Anti-diabetics, analgesics, antidepressants, warfarin, these are all commonly used drug classes and medications. And we found that the combination of drugs and the alcohol interacting combinations were varied by age and gender. So for example, men in the oldest age group, which was 75 to 84, were significantly more likely to drink regularly and concurrently use analgesics and psychotropic medications compared to men that were 57 to 64, who were more likely to use anti-diabetic agents in combination with alcohol. Then we found that women 57 to 64 were more likely to use psychotropics, whereas women in the oldest age group were more likely to use aspirin in combination with alcohol. So the combinations of alcohol interacting drugs varies by age and gender, and that's important to understand the types of medications that should be potentially avoided if possible, or interventions are necessary to prevent their concurrent use with alcohol. Next. So these next few slides focus on our use of NSHAP data, and this is preliminary, so unlike the other studies, this is not published, and it's using the wave 1 data. We're looking at kind of conducting a similar study over time using the various waves, but it illustrates kind of the strength of the data and how it could be used and linked with other NSHAP measures. And then in this case, it's the sleep measures to look at, not only the patterns of use, which you see here in the screen. So, what is the prevalence of use of medications that have insomnia side effects. And we see that, it's about a third overall, and it increases with age in both men and women, with the exception of women in the oldest age group. The orange bars using one medication and the gray is 2 or more. So we see even the multiple use of medications with insomnia side effects is at least 10 to 15% of the older adult population in wave 1. And, there's some commonly used medications that we found to be the most prevalent overall. Next. So the question here wasn't only, to what extent are they used in the older adult population, but does their use really affect their sleep, and particularly insomnia, which we know is a problem in the older adult population. So we conducted kind of a simple analysis to look at the prevalence of use of multiple medications, so 0, 1, 2 or more, and whether that's associated with insomnia or a series of symptoms that are often used to measure insomnia. And insomnia was measured here as 2 or more insomnia symptoms, which are sleep duration, 5 hours or less, sleep restless, feeling restless, and daytime sleepiness. And what we found is that overall, the more medications you use that have insomnia side effects, the more likely you are to have insomnia. Again, cross-sectional analysis, but I think it is an interesting finding and would motivate future research in this area in terms of the role of medications in contributing to problems like sleep, but also other problems that are captured in NSHAP, like sexuality or sexual dysfunction, cognitive impairment. There's a lot of work on that, and depression. We did some work on depression, not using NSHAP, but using NHANES, but NSHAP could also be used to look at that. And these findings persist in adjusted analysis. So using 2 or more medications, you're more likely, twofold more likely to report to have insomnia than those not using any medications. And even if you're using one medication, your risk is almost twofold as well. And it varies by symptoms. Again, preliminary analyses, but really illustrates how the data could be used and integrated with other measures. The medication data could be integrated with drug safety software to measure side effects, but also to examine the burden of the medication use on certain outcomes that are not clinical, but more of a social mental health dimension that NSHAP captures. I think that's it for me.
Thank you, Dima.
You're welcome.
So I'm going to kind of connect the drug data with the other forms of data that are available in NSHAP. So just using diabetes as an example chronic condition, we have within NSHAP have at least 3 different ways of identifying a condition. So we have self-report during the survey. NSHAP includes questions such as, has a doctor ever told you that you have diabetes or high blood sugar? And with every wave, for those who don't have a diagnosis, we revisit these questions around common chronic conditions. As mentioned earlier, we also have the dry blood spot assays. In the case of diabetes, we have hemoglobin A1C as a way of identifying diabetes or pre-diabetes, and we can use something like the ADA definition of diabetes based on an A1C, which is an A1C at or above 6.5%. And as Dr. Cato beautifully described, we have this real-world collection of medication and over-the-counter and supplement therapies that patients are taking. We know that from the brown bag assessment that they are taking these regularly. So we can also identify people who might have a condition like diabetes based on the type of medications they're taking. In the case of diabetes, taking a glucose-lowering medication is a signal that somebody has the condition. So this just illustrates the overlap of two of these three forms of data, and this is an example of an attempt to validate the medication as a and relate the report of taking medication with different kinds of biomeasures. So one commonly prescribed drug that has for hypertension and cardiovascular disease prevention is a beta blocker. And beta blockers are known to slow the heart rate down. That is one of their modes of action. So you can see that if we look at the pulse of people who are and are not taking beta blockers, that the subjects who are taking a beta blocker have a slower pulse. On the other hand, we do prescribe beta agonists for people, and they have the opposite effect of a beta blocker. They can increase the pulse, and in this case, those who take beta agonists have a slightly higher pulse compared to those who do not. And with regards to glucose-lowering drugs, those who report taking a diabetes medications tend to have a hemoglobin A1C in the diabetes range, while those who do not take diabetes medications tend to have lower blood sugars in the normal range. So these are just a little bit of validation of the medication and their intended effect on different biomeasures. And so this is a similar assessment where we have looked at the overlap of patient self-report. So we're not looking at the self-report and the biomeasure. In this case, we have people, and we also have the advantage of also looking at people over time across multiple waves of data. So you can see here that for those who report no diabetes across both wave 1 and wave 2, they tend to have A1Cs that are persistently in the non-diabetic range. Those who had undiagnosed diabetes in wave 1, so they did not report they had diabetes, but their blood sugar was elevated, they tended to have A1Cs that were higher, around 7. And then there were people who were diagnosed the entire time, and they tended to have higher A1Cs as well. This group had undiagnosed diabetes in wave 1, but they reported an interim diagnosis of between wave 1 and wave 2. They tended to have a higher A1C than those who remained in the diabetes range but were undiagnosed, suggesting that there is potentially these subjects in this row may have had presenting symptoms like polyuria, polydipsia associated with the higher A1C. This illustrates to you how we can use the two sources of data to say something. And then this actually brings it all together, showing the triangulation of all three data sources, self-report, taking a glucose-lowering medication, and also having a high A1C. And you can sort of see from this that the world is complicated, and that we actually have almost every type of subject represented. This highlighted group is particularly interesting because they are taking glucose-lowering medication for diabetes, but they don't have a diagnosis from a doctor, and they don't have an A1C above 6.5%. This group might have what we call pre-diabetes, possibly, but not, or they may have diabetes and not realize it. So in the interest of time, I will just show very briefly these unpublished studies, analyses looking at the relationship between gender and supplement use, which Dr. Cato alluded to. But in this case, we're looking at the differences in supplement use by couples. So I'll go straight to this kind of innovative analysis that we can do within NSHAP, which is to use couples and to look at the at how wives affect husbands and how husbands affect wives in terms of the use of supplements. Interestingly enough, in the era of the COVID-19 pandemic, use of common supplements such as vitamin D are thought to potentially have some protective effects. So these, understanding the dynamics of who picks up a supplement and uses it is actually pretty important, I think, from a public health perspective, both for safety, but also now for the potential protective effects of for COVID-19. So the bottom line of this graphic is to show you that it turns out that the wife's education level and the wife's age, the physical activity of the wife, that determines whether or not the wife takes the supplement. But the wife's characteristics also determine the wife's education, and smoking status also determines the husband's supplement use. And there are actually very few variables that predict of the husband's own characteristics apart from his race that determine supplement use. Could be telling us a story about the internal dynamics within the home of why a supplement is purchased and used. So the medication data in NSHAP is comprehensively collected and coded. It represents real-world use of medication by subjects. It includes, importantly enough, supplement data and over-the-counter drug data that just is not represented in other national studies and not in pharmaceutical claims. NSHAP also has dry blood spot data that is routinely collected each wave, and the next wave will include self-collection device dry blood spots. And the availability of medications, dry blood spot assays, and survey responses allows us to have multiple approaches to defining condition states. So I am quickly going to pass this on to Dr. Shum.
Thank you for, so thanks, Dr. Huang, for that. I'm just going to offer a few brief comments regarding some additional data and analytic issues involving the medication and the blood spot data that you've heard about. I'd like to address just briefly at the beginning. I know that we've already had one question about sort of the COVID pandemic and how it's affecting our study. This particular presentation was intended to focus just on the medication data and the dry blood spots, although as Louise mentioned at the beginning, we actually have, under her direction, we actually have completed data collection this fall from all of our NSHAP respondents, and so we will actually have quite a bit of data from these folks during this time. So the medications first, as Dima already remarked, you know, the NSHAP medication data are more comprehensive than lots of other population-based studies, being not limited to prescriptions only, like HRS and NHANES are, not limited to the last month, as with NHANES. And then NSHAP, for those of you familiar with the data set, and as you've heard a little bit in the previous webinars, has a really rich set of health measures that go beyond some of those standard ones that are included in other studies, including measures of sleep, as Dima has alluded to, or described here, and measures of sexual dysfunction. And so that makes it an excellent data set in which to look at the impact of medication use and polypharmacy on a number of outcomes. The medication data are very high quality in NSHAP. Only about 1 to 2% of respondents refuse to participate in the medication log, so the data are really quite complete. And the full 3-level hierarchical categorization of the individual agents that Dima described in her slide is all available in the data set. And then in addition to that, each of the categories, we've added an indicator, a 0-1 variable in the respondent level data set, indicating whether the respondent at that wave was taking or reported an agent in that particular category. And so that makes it very easy to start using the medication data. Now, analytic issues, there are three ways that you can, at least three ways you can use the medication data, and you've seen examples of each of them here today. You can use them as a dependent variable to study use of a particular medication or class or polypharmacy or drug interactions, as Dima has shown. Both cross-sectionally and longitudinally, we've collected our medication data since the very first wave of NSHAP in 2005 in exactly the same way. So we now have 3 waves on that, and we'll have a fourth once our next wave of data collection is complete. Medication data are often used as an independent variable, and that can be both static and time varying. And then finally, as Albert alluded to, you can also use it to derive or enhance measures of chronic conditions. So in the example that he gave with diabetes, the presence of using or reporting medication drug or a diabetes drug along with your A1C value and report of physician diagnosis of diabetes gives you 3 different ways, either to truly verify that a respondent has the condition, or to determine whether a physician has intervened in the case of a prescription medication. For cross-sectional outcomes, the analysis of the medication data is fairly straightforward, partly because of the lack of missing data, but partly also because we tend to treat these as though they're objective measures without error. They're, as Dima mentioned, recorded from the medication bottle by the interviewer. So we expect that there's very little, if any, measurement error here. And so for cross-sectional outcomes for the medication data, many of these analyses revert to either a logistic or an ordinal logistic regression model. For longitudinal outcomes, one might consider either a marginal model, that is changes in the average likelihood of taking an agent or a class of agents, or transition models, which allow you to actually look at the individual level, whether a person has from one wave to the next picked up use or added use of a particular agent or a class, or actually dropped it. Now, in the case of the dried blood spots, things are a little trickier. For those of you who are familiar with our data, this was only administered to 2/3 of the respondents in wave 1, and a random 2/3, but then the blood spots were administered to everyone in wave 2 and wave 3 and subsequent. There is a bit of item non-response. It's actually quite good, but somewhere between 10 and 15% for a given assay. Either the respondent refused to provide a sample, or there was some problem with the sample or the assay for that sample. And I can't remember whether it's mentioned yet or not, but we are currently conducting our assays on the 2015-16 samples. And so those will be made available to the research community as soon as we actually have the data and have QC'd them. In the actual data set, there are flag variables included in the data set for each measure that indicate, in some cases, that a sample simply exceeded the upper or lower bound of the assay instead of yielding an actual value. In those cases, there are various ways to handle those. In the case of an analysis, you can use censored regression. You can use an ordinal logistic model in that case. There are a number of things that you can do. And these also indicate if there were problems with a sample. Generally, our QC on the blood measures is excellent, but in a few cases, there's an issue that pops up, and all of that metadata is preserved in the data set for the analyst to have. there's a lot of information for those of you who haven't used these measures or may not have used dried blood spot measures before, a lot of information available on calibration of dried blood spot measures relative to the corresponding clinical assays. We've published some of that. Quite a bit of that has been published by others. Tom McDade, who's really been a leader in the field here, and a number of those have published that. So if you're looking to have that information in your analysis or to inform your analysis, it is definitely available. In the case of the dried blood spot measures, again, one can consider these both as an outcome, both cross-sectionally and longitudinal. The one thing here that I would point out is critical is when you're using one of the dried blood spot measures as an outcome, you really have to give a lot of careful thought to what you include as covariates. And I'll give you a perfect example, just sort of to loop around here. The medication data often are critical covariates in an analysis. If you're looking at A1C, for example, as an outcome, as Dr. Huang showed, whether or not you are taking diabetes medications really affects that, and to leave that entirely out of your analysis would likely be problematic for interpretation. So that becomes very important here. And then also, these are often used as covariates. The one point I would point out here is that unlike the medication data, these definitely have measurement error, as would any biological assay. Not only measurement error, but short-term variability as distinct from longer-term variability, which is often what you care about in a longitudinal study of this type. And so you really need to consider that. That will tend to reduce the magnitude of your effects, of your coefficients for a DBS covariate. Means that you're under adjusting for it if you're using that to adjust for, and so forth. A couple final things just very quickly. We encourage you to avoid using cutoffs whenever possible. We understand that sometimes for interpretation and to relate to the clinical literature, it's important, but you lose a tremendous amount of information when you use those. You might consider using transformations. Log works very well for CRP. In the case of analyzing change over time, we really strongly encourage you to use longitudinal models here rather than to use, say, the time one value as a covariate, largely due to the measurement error issue I mentioned above. And then finally, until our 2015-16 data are available, simply keep in mind that if you're analyzing change in these DBS measures from 2005 to 2010, or wave 1 to wave 2, you're doing that conditional on people surviving between those two time points. And that means that you're getting a different estimate of that change than you would have if you didn't have that attrition in the data set. So I'll stop there so that we can get a few questions in here.
Thank you, Phil. We are a little bit short on time. I wanted to start by just addressing some general points or questions that have come up. So the point of this seminar is to introduce people to NSHAP data. If more information is needed, we have a website, and I think Jen will have that available for us to view, and it'll be up on your chat, and you can access that for more information. There are very detailed content, like scientific papers written that deal with the issues raised about confounding the covariates that we might want to use, the other statistical issues that have been raised. But for present purposes, we hope that this will give you an introduction to the data. So Jen, anything you want to highlight from our questions right now?
Yes, I'm just going to go ahead. With your huge sample and the description geared large number of scientific tests, the likelihood is high that a marked portion becomes significant by chance. How do you guard against alpha errors?
Just very briefly, that's a good question. Probably one of the biggest ways that we guard against them is we try and minimize the amount of null hypothesis significance testing we do. When looking at a observational data set like this, the null hypothesis of a coefficient that truly is 0 is typically not of any interest. And so we tend to focus instead, whenever possible, on estimation and the precision involved in that estimation. And then secondarily, when we're looking at comparing a number of different possible estimates, pooling those with some kind of hierarchical model.
Thank you. Do we have time for one more?
It seems not, Jen,
Okay.
but everyone should know that these questions and answers to them, to the extent possible, will be available on the website. Is that correct, Jen?
That is correct.
So with that, I'll turn this back to Judy. Thank you all for attending and taking an hour out of your day to learn more about NSHAP.
Thank you all again for participating. In particular, we want to thank all our panelists and our organizer today. This is the end of the program.